Hello, my name is Anya Sirovatka. I'm a postdoctoral research fellow at the Brigham and Women's Hospital and Harvard Medical School. This presentation will describe the testing of a novel inpatient respiratory depression electronic clinical quality measure for orthopedic practice in two large U.S. health systems. I would like to thank and acknowledge the large team that has supported this work. This project was supported by a grant from the Centers for Medicare and Medicaid Services, and the content of this presentation is solely the responsibility of the authors and does not necessarily represent the official views of the CMS. Postoperative respiratory depression is a serious event that places patients at risk of severe brain damage, cardiac arrest, and death. Guidelines exist to help healthcare providers identify higher-risk patients and prevent respiratory depression through appropriate monitoring and evidence-based interventions. Key challenges to accurate and comparable measurement are lack of a universal definition, variability in measurement approaches, and heterogeneous populations under study. There are no reliable diagnostic codes to document the occurrence of respiratory depression, but rather codes focus on related outcomes such as respiratory arrest. Furthermore, respiratory depression can be evaluated using a variety of methods, including respiratory rate, oxygen saturation, and heart rates below or above certain thresholds, to name a few. However, even when using the same method, different thresholds may be applied to define the presence of respiratory depression, making estimates of the incidence of respiratory depression less comparable. Metrics using data routinely documented in electronic health records could help to overcome some of these challenges and allow for more accurate measurement by leveraging data elements not available in claims data, such as vital signs. The objective of our work was to test an electronic clinical quality measure, or ECQM, that reports on the inpatient respiratory depression rate following total hip or total knee arthroplasty in two large U.S. health systems that use different EHR vendors, specifically Epic and Cerner. There are numerous benefits associated with developing an ECQM over a claims-based measure. Leveraging EHR data provides access to more information, which improves the accuracy of the measure. It allows for assessment of all adult patients rather than being limited to Medicare beneficiaries. It decreases the burden of performance measurement by using data routinely collected in the EHR, which in turn allows for more timely reporting. And most notably, healthcare providers can access performance data in near real time to track progress and facilitate continuous quality improvement. We used an iterative process to design and develop the ECQM. We engaged key stakeholders to inform development. We sought guidance and feedback on measure specifications and the value of reporting the proposed measure through structured interviews with patients, orthopedic providers, and payers, as well as consultations with a technical expert panel. We also received feedback through public comment. We also conducted reviews of the published literature, related clinical quality measures, and clinical guidelines. Here are the specifications that were developed for the ECQM. The denominator includes all adult patients aged 18 years and older who received an inpatient elective primary total hip or total knee arthroplasty covered by any healthcare payer. We harmonized exclusion criteria with existing National Quality Forum endorsed orthopedic clinical quality measures. We also excluded patients discharged against medical advice and those who had more than 2 hip or knee procedure codes documented during the inpatient stay. Since the measure focuses on inpatient respiratory depression, we also excluded patients who received an outpatient procedure. The numerator included patients who experienced postoperative respiratory depression during the inpatient stay as defined by at least one of the following being documented in the EHR: a diagnostic code for a respiratory depression-related outcome, or a procedure code for mechanical ventilation or intubation, or oxygen saturation levels below 88%. We selected a conservative threshold of 88% to account for the 2% margin of error on readings. We tested the measure using data routinely collected in EHRs at two large urban academic health systems, the Mass General Brigham, which uses Epic, and a geographically distant system in the southern U.S. that uses Cerner. We calculated descriptive statistics to characterize the sociodemographic information of the cohorts. We then calculated unadjusted and risk-standardized inpatient respiratory depression rates for each health system overall and for each orthopedic clinician group to assess variability in performance between groups. Rates were adjusted for age, sex, race, primary language, household income, type of insurance, orthopedic procedure, body mass index, smoking status, and relevant comorbidities. The ECQM rates were reported as percentages, where lower percentages indicated safer care. We assessed reliability and validity of the EHR data required to calculate the measure, as well as the proposed measure specifications. The table shows the demographic characteristics of patients from the two health systems. The cohorts were similar with regard to many characteristics. However, the southern U.S. cohort had greater racial diversity, a higher percentage of patients covered by public insurance, and a lower median income. Both health systems had a similar breakdown by orthopedic procedures. At the Mass General Brigham, 45% of patients received a total hip, and 55% underwent a total knee arthroplasty. At the Southern U.S. system, half the patients received a hip arthroplasty, and the other half had a knee arthroplasty. The two tables show the unadjusted and risk-adjusted ECQM rates for each health system. 6 orthopedic groups from the Mass General Brigham were included in the measure calculation, and the overall unadjusted rate was 3.3%. Rates were risk-adjusted using a hierarchical logistic regression model, which was used to calculate the predicted over expected, or P over E ratios. The ratios were then multiplied by the unadjusted rate of the total cohort, including both health systems, to get the risk-adjusted rates. The overall risk-adjusted rate for the Mass General Brigham was 3.83%, and clinician group rates ranged from 2.84 to 4.35%. 11 clinician groups were included from the Southern U.S. system. The unadjusted inpatient respiratory depression rate was 3.05%. The overall risk-adjusted rate was 2.73%, with clinician group rates ranging from 1.4 to 4.3%. The interclass correlation coefficient was around 0.07, indicating that only 7% of the variation in rates was explained by the clinician groups. We assessed data reliability and validity to determine the accuracy and feasibility of calculating the ECQM using routinely collected EHR data. Overall, the Mass General Brigham EHR captured 99% of the necessary data for risk adjustment, and the Southern U.S. EHR contained 98%. The table on the left shows the data element availability for each variable. Most data were near complete, however, data on smoking status were missing for approximately 13% of patients who received their procedure within the Southern U.S. system. Manual chart review of 230 randomly selected patients at the Mass General Brigham confirmed that the data required for measure calculation were available in the EHR. The table on the right shows the agreement between manual chart review and ECQM classification of patients from the Mass General Brigham. The percentage agreement was 97.5% in round 5 of chart review, with a corresponding cap of 0.96, indicating excellent agreement. In the few cases of disagreement between chart review and the ECQM, it was determined that the ECQM classifications were in fact correct. In order to test measure reliability and validity, data were randomly split 50-50 into test and validation samples. The measure showed strong reliability. The predicted over expected ratios for both samples resulted in similar rankings of the 17 clinician groups with a Spearman's rank order correlation of 0.77. The model also showed good discrimination between patients who experienced inpatient respiratory depression and patients who did not. The test and validation samples showed reproducible C statistics around 0.77. The Hosmer-Lemma goodness of fit test had p-values greater than 0.1, indicating a good fit between the observed and expected results. The measure has a few limitations. Only 7% of the variation in rates was explained by the orthopedic clinician groups. The ECQM was tested in 2 large urban high-performing health systems, and we would expect to see a larger percentage of the variation explained by clinician groups with the inclusion of additional health systems. We initially developed the ECQM to report at the orthopedic clinician group level for the merit-based incentive payment system. However, prevention of inpatient respiratory depression is clearly a multidisciplinary issue, and it may be more meaningful to report at the hospital or health system level. Notably, each orthopedic group in the study represented 1 hospital, meaning that the rates are also applicable at the hospital level. As a next step, we aim to determine the most appropriate level of attribution. Another limitation is that the measure population is expected to change over time, as lower risk hip and knee procedures shift to outpatient care. Although this will impact the ability to interpret trends over time, the measure may become more meaningful as it is applied to populations of more complex and higher risk patients who are more likely to experience this complication. This highlights one of the strengths of implementing the measure as an ECQM rather than a claims-based measure, which is access to data in real time, which is more flexible and adaptable for managing dynamic populations. In conclusion, the results showed that there was variability in performance between orthopedic groups, which demonstrated that this is a meaningful measure and also highlighted opportunities for improvement. Both the data and measure specifications demonstrated strong reliability and validity to allow for calculation of accurate rates of inpatient respiratory depression following total hip and total knee procedures using routinely collected EHR data from 2 large academic health systems. Testing showed that the ECQM can be implemented within Epic and Cerner EHR systems to facilitate automated reporting of performance to CMS. The overarching goal of our work is to obtain National Quality Forum endorsement and have this ECQM implemented as part of the CMS Quality Payment Program to provide meaningful performance measurement that can be used to drive local quality improvement. Thank you very much for listening to the presentation. For more information, please see our paper, which will be published as part of the MedInfo 2021 conference proceedings. We'd be happy to answer any questions by email.